All right, perfect. So, plantar fascia. This is probably one of the more common things that you're used to have, looking at an ultrasound image and visualizing the plantar fascia. This can be really helpful for looking for whether you've got plantar fasciitis or a tear, rupture. We can also look whether the person's got sort of subcalcaneal bursitis. This can be really common, and it can almost present very, very similar to plantar fasciitis, where they will, and the sort of patient with this subcalc bursitis, they'll generally be an older person or an older person or an overweight person, and there'll be often a bit of degenerative change to the fatty padding. So what ends up happening is when you're palpating them, they're not tender on the right spot. They're tender under their heel. They'll have that pain first thing in the morning. It'll almost mimic plantar fasciitis, but when you go to palpate them, you can't find the spot. Um, Okay, those patients generally will tend to have some sort of subcalc bursitis. You then have a look at you can use your ultrasound to have a look at one. We can look at I'm just going to bring this up. So we can see here to orient ourselves, remembering that the top of the screen, this is going to be which echoes return closest. So this is our skin. We've got our fat pad here. We've got our calcaneal medial tuberosity. And we've got the plantar fascia coming in and inserting into that. Then we've got our flexor digitorum brevis underneath here. Okay, so it's our sort of orientation. When we've got pathology, what we're used to seeing is the increase in thickness and a change in the echo texture and echogenicity. So it'll go from hyperechoic, being quite bright, to hypoechoic because we've got little micro tears that are developing and we've got this increase in ground substance and we've got some degenerative changes there. But it can be really helpful to have a look at, looking at all of those structures, not just the thickness of the plantar fascia, right? We're looking at is the bone margins nice and regular, or do we have a large heel spur? Do we have swelling in the fatty padding? And dynamically, we can also put pressure on the fat pad to see whether it's easily displaced because you've got those, because it's that loculated fat pad, we've got these fibroadipose that hold almost cells of fat. It's a bit like bubble wrap. When we get older, those fibroadipose start to break down. So when they stand, the fat squishes out the side and then they're basically sort of walking on the bone. Those people are going to develop things like subcalc bursitis, plantar heel spurs, and usually some fasciopathy as well, because we've just got this chronic overload in the heel. And we're used to sometimes with forefoot pathology, people can have multiple things that are all contributing to pain. They can have a degenerative plantar plate tear, an intermetatarsal bursitis neuroma complex, and even so we can have three things that are causing pain, and clinically you sort of got to work out, okay, the concept is there's a chronic overload in that area. The heel's very similar. You can have multiple tissues that are generating pain. It can be the heel, the bone itself. We can have some bone marrow edema. We can have edema in the superficial tissue and calc. And we can have fascial pathology. So it's about sort of working out which structure are we dealing with. This is our orientation. So this is our long axis view. So most commonly when we scan the plantar fascia, it's in long axis. So again, the sonographer is putting some tension on the plantar fascia, so we can see that nice taut band through there. There's the calcaneus. And just in terms of anatomy, we've got our medial tubercle where we've got this sort of central band here, and this is our lateral band. And this lateral slip of the plantar fascia inserts into the base of your styloid process. This is actually what causes a styloid and avulsion fracture. It's not peroneus brevis. Brevis inserts on top of when we look at brevis, it inserts on the dorsal aspect of the fifth metatarsal. Our plantar fascia slip, the lateral slip, inserts on the plantar aspect. When we roll our foot, it's the plantar aspect with that taut band of the fascia that basically breaks the styloid off. It's not peroneus brevis, which most people, so one of the things that can sometimes happen is you might have a patient that comes in with focal tenderness on that styloid process. you're palpating it and you go, wow, this patient's got insertional peroneus brevis tendinopathy. You then refer them off for ultrasound and it comes back negative. Those patients will have fasciopathy of that slip. Yeah, yeah. They'll appear pretty similar, but when they do a scan, typically in radiology, they often won't scan that underside. They'll look at the tendon. They'll look at brevis. So you can get a scan come back and you go, this is really odd. This patient's really painful. They're having trouble weight bearing, and the scans come back saying peroneus brevis is intact, unremarkable. It's typically underneath. This is looking at some pathology. We can see through here we've got a thickening. So this is our plantar, our calcaneal medial tubercle. You see how we got a shelf of bone here? Rather than that being nice and smooth and dropping off, we've got a shelf of bone. So we've got a calc heel spur there. And we can see this nice thickened plantar fascia. It's thickened. We've got these regions of where it's hypoechoic. And it's also heterogeneous, meaning that we've got that mixed echo. We're getting that as we've got the degenerative change, we've got a mixed echo from that structure. So this will tend to indicate we've got some sort of micro tearing and quite a bit of degenerative change. They've found a tiny little bit of microflow on power Doppler, but typically that's not, it's very hard. You need a very, very sensitive machine to pick that up because plantar fasciitis is typically not very vascular, as is, say, you might get infiltration of a mid portion of an Achilles. It doesn't usually happen with the plantar fascia, but if it's quite inflamed or the person's had a intrasubstance tear, you will see some inflammation in that area, and that will often show up with a bit of hyperemia. We can have a look at this one. See, this is a nasty plantar fascia. This is one where we've got this big sort of bulbous thickened plantar fascia. See here, we've got this anechoic cleft through here. So we've got a tear here, but then this area through here, the deep insertional fibers is very hypoechoic as well. So we don't have normal fibrillary pattern through there. So this is a common area where we get pathology, where that plantar fascia inserts into the deep insertional part of the bone, and this is often where they tear, because mechanically, if you think about where the fascia is going to move around that smooth surface, and if we've got an irregular bone there, that's going to, it's a bit like a rock climber where they've got rope that's hanging off a sharp piece of rock. It's not usually a good idea. It'll last for a while, but then over time you can get an increase in wear and tear on the rope. Same thing happens with the fascia. This is what that looks like in short axis. So ultrasound, we always want to see pathology in two planes. So if I see this image here and I go, okay, well, that looks like a tear. We've got this, we have this little anechoic, meaning there's no reflective, the ultrasound's not being reflective at all. I want to rotate my probe into short axis and I can see there's a hole here as well. So I know that this is actually pathology and it's not just artifact, because sometimes the position that I might be in with my probe, this may make this look darker than it should be. And if it is artifact, when I rotate into short axis, I won't be able to see that. Okay, so you can see how I can actually see fiber structures around here. That looks normal. Not normal in terms of non-pathology, but I can see fiber structure, and then we've got this hole there. So we know that we're dealing with a tear. This is often what like a fibroma will look like, or even a partial where they've ruptured it. So these sort of injuries, this one looks more like a rupture. It's very disorganized. These happen sometimes in younger people where they might be a basketballer and they'll feel a pop underneath their foot. Sometimes they can get a bit of bruising there. Sometimes there may be no bruising, and basically what happens, they've got usually a partial thickness rupture of that plantar fascia, and then as it heals, we just get this sort of lump of scar tissue that forms, which is thickened and hypoechoic. But a fibroma can look similar too. Comes down to the history. If we're dealing with a fibroma, you typically don't have that sort of inciting event. Whereas if you've got a basketballer or a footballer and they feel a pop underneath the foot, that's typically where, we look for. But the plantar fascia can rupture in the insertion as well, in a healthy one. So we tend to break them down into, you can develop an intrasubstance tear or delamination in someone that's had like long-standing heel pain. So they might have had heel pain for a long time, right? And then what happens is they're managing it themselves with exercise. They might have seen the doctor or physio, and then all of a sudden they get this flare up in pain. They can't weight bear properly on the foot. They're really tender. The heel might often be swollen. Those people often have this sort of acute on chronic flare in pain. And when you scan them, there'll be 9 out of 10 times a split or a delamination tear in the plantar fascia. Because it's more of a continuation, right? If you think about like a continuation of degenerative change in the fascia, where it continually gets more frayed, those intrasubstance tears become larger, and then we get towards the end, we start to get a decent split that forms. So it's more of a continuation. It's different to someone who's healthy, young, nice looking plantar fascia, acute injury where it ruptures. They're a bit different just in terms of it's more part of that progression as opposed to, so sometimes they respond well to things like prolotherapy, because we're trying to get, we want some sort of scarring to occur, stick that together. I've also used PRP on those patients as well, where there's a decent tear. It's really not responding to conservative treatment. It's not so much the size. When they're delaminated like that, the size doesn't really, they're really, they look like Swiss cheese. You got a slice of them and they look like this little holes. So when I see that, the cross-section view where I can see how heterogeneous it is, that tends to tell me what it's going to respond to as well. If it's really delaminated and there's intrasubstance tear, my preference is usually to go with an injection. Whereas if it's not really delaminated, they'll respond well to shockwave. Really depends. It depends on the patient. It depends on the patient. But when they're really delaminated like that, they don't tend to respond well to shockwave. That's why knowing how bad it is in terms of being able to visualize that can be really helpful, because when I see it like that, I change the expectation with the patient. I'll typically say to them, listen, shockwave when it looks like this, 50-50. Might help, it might not. We do 3 sessions. If we don't get a response, we recommend an injection. Otherwise, we can do an injection sort of straight up if you've tried all those other various things that you're doing, strapping, things like that. I don't put, when you've got a degenerative tear like that, I don't put them in cam boots. Chronic tear, it's different, right? An acute one, I might put in a cam boot if they're having trouble walking. But in a chronic one, I used to, but when they come out of it, because the pathology, the ligament and the fascial insertion so degenerative, that what ends up happening is they're not better. They're maybe 40% better, right? So you're helping them get around walking wise, but it doesn't resolve their problem. I will tend to put them into a tri-lock brace. If there's a lot of bone edema, again, what I would tend to probably do is go tri-lock brace and a very cushioned padded shoe, even something like a Hoka or something like that, to just try and deload, take it as much as possible. My preference is not to go cam boot because I think they get overused a lot and people get left in them for ages. I see people come in with cam boots for 10 weeks and there's not really a clear treatment plan that they're sort of working towards. So I've used them in the past and they do help. The patient will be happy because they'll come in so much pain. You put the boot on and they go, wow, I can walk without pain in the boot. The problem is 6-8 weeks later, they can't. They're very deconditioned when you try to bring them out of the boot, and the pain's still there. It's not like the pain's gone away. Yep. Aggressive taping. I use tri-lock braces, stabilize the medial hindfoot. Um, that's actually more my go-to now for plantar fascial tears. It's a bioskin brace, and it's got various sort of straps. I like those. No, this one doesn't have laces. It's the original one I gave you, not the ASO. It's not an ASO. It's really useful. I use them for say I use them for tib post. So because what I'll do with these people is I generally will progress them. So I don't like to do a lot of things at once because you don't know what's working and what's not, right? So I've got pretty strict protocols that I use with variations for these presentations. So someone comes in with a real acute tib post issue or something like that. So my tib post one, I don't even consider orthotics for 6 weeks, right? I put them into a tri-lock brace and I get their pain to come down by about 80%. And then we progress them onto an orthotic. Because if you put an orthotic straight in there, they won't tolerate it and you have problems. Whereas if you go in that order and you settle them down, then you get a much better response with your orthotic, but they also tolerate it better and their pain has come down so much. You you could use an ASO. They're sort of similar. An ASO I generally would use more so for, say, netball or something like that, but they're similar. It's both got some straps and things like that. So this is a case study. So this patient is a 40-year-old lawyer. This has happened during lockdown when I was working in CBD. This patient presented acute onset. So this is during one of the big lockdowns, and she was stuck in her house. Single woman in a small apartment in the city, working away all the time. So she decided I got to start doing some walking. She's not overweight, but she has had an acquired brain injury, and her gait was a bit affected with that. So she decided, okay, I'm going to start going and doing some walking. She decided pretty much first 2 days, she's done like 12 kilometers in a row, and then she's had this massive flare up in pain. Both her parents they're quite well-known specialists, and they've told her, look, you've got plantar fasciitis. Think you'll need an orthotic, go see a podiatrist. So I have a look, and this woman comes in, and she's not weight bearing properly on that heel. She sort of limps into the room. When that happens, I'm usually going, okay, there's plantar fascial tear. I scan her plantar fascia, and let's have a look here. So here's our calcaneus, and here's the plantar fascia inserting into that, and here's our fat pad up here. How do we think this looks? Does this look normal or abnormal? Normal. Yeah. We don't see thickening of the plantar fascia. There is a bit of fluid in the fat pad through here, but that doesn't explain the patient's symptoms. The bit of fluid, the tiny little bit of fluid in there, right? But the bone's normal through there, fascia's normal through there. So then when I look at that abnormal, and she's actually not overly tender underneath the heel. So that's really helpful because I can rule out plantar fasciitis as a diagnosis. Finished. Then we can expand the scan as well. So if it's not plantar fasciitis, what would I expect? We've got someone who's deconditioned, who's had a sudden increase in activity. Yeah. Her Achilles tendon I check. Again, it looks completely normal. Okay. Then I start having a look on the inside of the keel bone. And this is the medial part of the calcaneus. It's not a very good image, and based on this image alone, I wouldn't be calling anything. But based on that whole clinical context, I can see cortical lifting here. And what happens with ultrasound is it can't penetrate through bone. So see how it's see the acoustic shadowing here is very dark? See how the acoustic shadowing opens up? So that's a loss of bone mineral density there because some of the echo is getting through the bone. And we got this little defect here. Then I put the power Doppler on there and I can see hyperemia of the periosteum. So in that case, patient has a stress fracture and I've put them into a boot without, but then I said, look, we'll get an MRI as well, but based on my clinical assessment, based on having ultrasound, I was confident enough in that to basically in that first consult to say, we're dealing with a stress fracture. I'm going to put you in a boot. We don't need to, I'm not going to delay it by a week waiting for an MRI and then waiting to see you again and then put you into a boot. So we can see there that sort of pulsatile flow there of the periosteum right against the bone, similar to where we got that little defect. And here's her X-ray, her MRI. We can see basically a big calc stress fracture, and there's all the bone marrow edema in her calc. But again, you can see that normal plantar fascia, normal Achilles tendon. Perfect. So we'll do a bit of a practical session now on the plantar fascia.